we get started, thank you for joining the scientific update for the COBRE and opioids and overdose. I'm Tracy Green. I co-direct the center. And today we're really excited to have a colleague, Mary Figgatt, who will soon be joining us as an F31 or as a fellow for the T32 rather. She's currently a postdoctoral fellow at the University of Alabama in Birmingham and has published a number of studies in this particular topic and critical area of around the health of people who use drugs. So we're excited to hear from her today on her recent research and prospects for future research in this area. I'm going to pass it over to you, Mary.
Yeah, sounds great. Thank you so much. And thank you for having me here today. I'm excited to talk with all of you. Today I'll be kind of going over a few different research projects that have focused specifically on measuring the impact of bacterial infections and wounds on the health of people who use drugs. So it'll be kind of a combination of a few different studies. So it'll be pretty brief, but I'm happy to go into depth on any of the studies if people have specific questions about the methods or any other analyses from those topics. So I'm sure many of you are familiar with this topic area, but just as kind of a brief overview before we kind of go into some of the details. So some of the bacterial and fungal infections associated with injection drug use that have been particularly identified more recently and, well, also just for decades. But some of the ones that I'll be talking about today are skin and soft tissue infections, so including things like abscesses and cellulitis. And then some of the more invasive infections like bone infections, bloodstream infections, and heart infections. And so we know that skin and soft tissue infections tend to be more prevalent among people who inject drugs, whereas some of these invasive infections are less prevalent. However, the invasive infections are much more severe and require a lot more care for people who go on to develop these infections. While skin and soft tissue infections can be more minor and can resolve with minimal treatment, they can progress into more intensive and more severe infections as well. So there are kind of a lot of different possibilities with some of these infections. And so we know that since the late 2000s, there's really been an increase in recognition of drug use associated bacterial infections across the United States. And in 2017 alone, it was estimated that there were about at least 100,000 documented people who had hospital visits for drug use associated skin or soft tissue infections. And then we also know that the prevalence of recent history with skin and soft tissue infections is high among people who inject drugs, specifically through a lot of different studies that have been conducted at syringe service programs. So one project that we did found that about half of people had a recent one of these infections in the previous year. So the work that I'll be going over is a lot of it's specific to North Carolina. So just to provide a little bit of background about what has been going on in North Carolina is, we had seen a similar trend in increases in overdose mortality as we had seen nationwide, particularly with this large increase starting in about 2013. One of my mentors, Asher Strands, had started looking into a lot of work for drug use associated endocarditis, noticing that there were similar increases and kind of, when we compared the trends of both of these health outcomes, you can see that there's, kind of a mirroring increase during these two times. So kind of overall, just to before getting into kind of some of the weeds with some of these studies, there has been a lot of work that's been conducted for a long time in this area. And so, going through kind of what was known prior to kind of exploring some of this research. We knew that bacterial infections were increasing in prevalence and had been mirroring overdose trends. But, in kind of talking with the community, we've heard a lot of anecdotally about people who had passed away from bacterial infections, but we really don't know on a quantitative scale what the contribution of these infections are to mortality and other sorts of long-term complications after people go on to develop these infections. We also know that medications for opioid use disorder, or MOUD, are effective treatments for people with opioid use disorder. But specifically when we're thinking about people who go on to develop these acute bacterial infections, we know that they might require different sorts of care in the hospital that might mean that they don't get necessarily initiated onto treatments or have the same opportunities as someone who is directly in the hospital for something like overdose. And also people who are, have treatment from these infections might require things like long-term antibiotics. So there can be different sorts of disruptions that make it difficult for people to receive MOUD and then stay on and access MOUD after developing one of these infections. So one of the gaps was really to understand, do we see the similar impact of effectiveness of MOUD among people who develop these infections? And then lastly, we know that people who use drugs face really complex structural barriers to healthcare, particularly in traditional settings. And so specifically, when thinking about infections and wound care, what barriers do people face and what are the treatment preferences? Noting that someone who has an infection might have different sorts of experiences when they go in to receive care than someone who has potentially something that might be less stigmatized within a healthcare setting. So I'll just start briefly going over the first question that we sought to look into, which is looking at the contribution of bacterial infections to mortality and long-term complications. And so the way that we tried to explore this topic was looking at two different cohorts of people with two sorts of questions. So overall, developing a cohort of people who had a documented healthcare visit for some sort of, where they also had a diagnosis for a drug use disorder, and specifically using what was on the healthcare claims. And then once people entered the healthcare system, looking at the incidence of mortality that were associated with bacterial infections, and then seeing how this incidence of mortality compared to overdose. And then specifically among people who survived severe drug use associated bacterial infections, specifically endocarditis, what was the incidence of mortality and subsequent infections? And the reason why I'm bringing up these two different cohorts is because, they might represent different populations where people who enter the healthcare system for the first time might have different long-term, incidence of mortality initially, whereas people who have their first invasive infection might have a higher incidence of mortality. And so in order to look into these questions, we created cohorts of people who had drug use diagnoses using statewide health records, and then linked those data with death certificate data, and then estimated the incidence of mortality and rehospitalization. And so specifically looking at people with drug use associated visits, this included public and privately insured adults. And the reason why we specifically included just people who had insurance was because we were able to capture things like beyond just hospitalization data. So we could look at outpatient visits. We could also look at medication records. And so the two outcomes that we looked at within this analysis was infection-related mortality. And so the reason why, we can't just look at death certificates alone to be able to see what the contribution of bacterial infections is among people who use drugs to mortality is because death certificates don't accurately code in a way that we can be able to really tell if somebody had passed away from a bacterial infection that was also associated with injection drug use. So once we create this cohort of people with drug use diagnoses, we can look at what happens to them over time. And in doing so, then we can also see of those who die during follow-up, how many people had a hospitalization for one of these invasive infections shortly before their death. And that kind of gives us a little bit more of a concrete measure than what we could do by kind of just trying to estimate with death certificates alone. And then we also looked at overdose mortality, and because this is more accurately coded on death certificates, particularly in North Carolina, we just use that data with the CDC definition. And so for the second cohort was for people who survived drug use associated endocarditis. And so this was all adults regardless of insurance status. So because these are much more severe infections, we would expect that the first instance of a visit would be hospitalization. So we're able to use statewide hospitalization records for this cohort. And we looked at all-cause mortality derived from death certificates, and then also looked at how many people had been rehospitalized for other bacterial infections, looking at endocarditis, but also some of these other ones, kind of just noting that someone might have endocarditis, but then they can go on to develop one of these other invasive infections as well. And it's not just going to be limited to reinfection with, heart infections. It could be other invasive infections as well. So looking at the 1-year incidence of mortality among this kind of larger cohort of people who first enter the healthcare system, looking at the first time that they had a drug use diagnosis, we looked at this by age group, specifically just noting how much some of these trends can vary by age. And so we see that bacterial infection mortality, was lower than overdose mortality, but it's not non-existent. And we see that it increases with age. And so I think, it is a notable contributor. And over time, as we kind of see some of these increases in bacterial infection, it's important to keep looking at this data to see how these trends change as well as things progress. And so then looking at people who survived drug use associated endocarditis, what we see is that the long-term mortality is pretty high among this population. So even when people survive an initial infection, endocarditis infection, there's still high mortality where 16% die within the first 3 years of follow-up. And about a third of people get rehospitalized at some point for another bacterial infection. And the leading causes of death when we looked at those who died during follow-up were drug use associated, like overdose, and then endocarditis complications. And some of the leading causes of bacterial infection rehospitalization were skin and soft tissue infections and recurrent endocarditis. Okay, so I'll move on now to thinking about kind of, we start with looking at what's the contribution of these infections and kind of moving towards what can we actually do to prevent things from, from some of these adverse outcomes from happening. And so since we know these medications are effective, we can see kind of what the impact is like among people who develop these infections. So for this study, we also used healthcare records, and I'll kind of talk about this a little bit more, but the use of healthcare records for some of these questions is pretty effective, especially when we're thinking about looking at longitudinal outcomes. So because these data already exist and are collected in a systematic way, it can answer some of these questions, whereas some of these more prospective active cohorts can take a lot more time and resources. So specifically when we're looking at things like medication use, where we're pretty sure that that's going to be documented, healthcare records can be a really good option. But I'll kind of get into this a little bit more about a lot of the limitations that are there when using healthcare records alone to kind of look at some of these questions that have a lot of social implications. So again, for this study, we were looking at the association between medications for opioid use disorder and specifically mortality among people who first came into the healthcare system with an opioid use associated skin or soft tissue infection. So this is kind of thinking more about, we know that people who, so that skin and soft tissue infections are some of the more prevalent bacterial infections among people who inject drugs. But we also know that potentially people might appear in the healthcare system a little bit earlier on with these infections, rather than some of the more invasive infections might come later. So if we look at the first time someone comes in with these infections, if we can offer MOUD as one strategy, that might potentially have an impact later on, from preventing invasive infections and mortality. So we compared MOUD use to no use, specifically within the first 30 days after they left the hospital for one of these infections. And our outcome was mortality, all-cause mortality. And we estimated this association by looking at MOUD and mortality using weighted incidence curves to calculate adjusted risk ratios. And so overall, the study population, about 16% of them had received MOUD in the first 30 days after their initial skin or soft tissue infection visit. I will say, first of all, this is MOUD in this analysis included methadone and buprenorphine. One thing was that the study dates that we used were from 2007 through 2018. So there was a lot of change in MOUD access during that time. And we specifically focused just on Medicaid enrollees because that was the only insurer at this time that was actually offering reimbursement for both of these medications. And we felt it was important to include both of them rather than just focusing on buprenorphine alone. And then overall mortality was also high within this population where 12% died within the first 3 years of follow-up, and nearly half were hospitalized within the first year after their first infection. So overall, looking at the incidence of the 3-year incidence of all-cause mortality, comparing those who received MOUD versus those who didn't within that first 30 days, we see a risk ratio of about 0.5. And so this is really consistent with the prior research looking at MOUD effectiveness within the general population as well. So that just highlights that it's even though we have a smaller percentage of people who receive these medications, it is very effective when people do get them. So now I'll kind of pivot to thinking about barriers to care and treatment preferences, noting that, medications for opioid use disorder are just one strategy in providing services for people who might be at risk of developing these infections or people who are managing these infections. But we need to also consider the difficulties in getting access to care in the first place and thinking more about what sorts of other strategies we can do to get people access to the services that they need, potentially, in consideration of what barriers, structural barriers are already there. So this study was really started as a partnership when I was at UNC, and we started a research collaboration with North Carolina Survivors Union, who's a harm reduction organization in North Carolina. And the goal of some of the work we were doing was really to try and come up with a few research projects that were in line with some of the things that they had been seeing in the community at that time. And so really making sure that the research we were doing was relevant to what was happening in the community, particularly kind of at the beginning of the pandemic. So there were a lot of different things going on. And, one of the things that they really highlighted was just how many people were coming in with skin infections and how much it had seemed to be changing during that time. So with them, we developed a survey, kind of getting at some of the questions that they had been noting among their participants as some of the major concerns. And we worked with 5 different syringe service programs across the state to administer this cross-sectional survey. And so we looked at, some of the study questions were really about, getting a sense of what barriers to care did people have, and what sorts of treatment approaches were they currently using at that time. And so the survey collected different things like skin and soft tissue infection history. We asked people about, for these infections, where did they get care, not just thinking about, at a doctor's office or in the hospital, but also kind of asking around within their networks. So what other sorts of alternate care approaches were they using? And then we also asked about what factors had influenced some of their treatment experiences and some of the, ways that they were navigating the system. And then we also asked generally about their healthcare access and then preferences for care in the future. And generally, this was a more descriptive study, but we did kind of look at what the association was between having access to a doctor that they trusted with drug use related concerns, specifically thinking about how that might impact the prevalence of skin and soft tissue infections. So within this study, we found that about half of people had a skin or soft tissue infection in the past year. And then nearly everybody who had one of these infections had said that at some point they had ever delayed or not gotten care for an infection. And so when we asked people about the reasons why, reasons for delaying or not getting care, it really fell into kind of 3 different categories. One was about, bad experiences that they had had with the healthcare system in the past, like judgment or mistreatment by medical staff, legal concerns when they went to go access care, like warrants or involvement of child protective services. The other category was logistical. So thinking that, people, it took too much time to get access, to go get care, the cost, transportation. And then lastly, a large amount of people had reported self-treating their skin or soft tissue infections as well. And so then looking in terms of what, potentially can mitigate or reduce some of the impact of these infections, we found that people who had access to a trusted doctor overall had a lower history of skin and soft tissue infections compared to those who didn't have access to a trusted doctor. Yet only about 30% of people actually had access to a doctor that they trusted. And overall, when we asked people about, what they would prefer in terms of like improving infection and wound care, They had suggested increased access to free antibiotics and on-site wound care at syringe service programs. Okay, so let's see. Yeah, just to summarize, through these studies, the contributions that we've kind of found were that bacterial infections are a notable contributor to mortality and other long-term infection complications. Oops. And initiation of medications for opioid use disorder after people develop infections are associated with reduced mortality. And stigma and structural factors are major barriers to infection treatment. And many people want low burden wound care offered in community settings. So just looking ahead, I wanted to acknowledge that a lot of this work was really done kind of at the time of the COVID-19 pandemic or even earlier before that. And so, things have really evolved since then. And I'm sure all of you are very well aware that the changes to the drug supply, and specifically with xylazine, has introduced a whole lot of new sorts of concerns that people are facing with these really severe wounds. And so while xylazine, the kind of evidence showing the association between xylazine and some of these severe wounds has become much more documented and kind of acknowledged, we still don't really know, as far as I'm aware, to like what extent xylazine exposure increases wound incidence among people who use drugs. And we also don't know why some people might be more susceptible to developing wounds than others. Also, for people who go on to develop these severe wounds, I think, we need to think about the fact that a lot of people have many interactions with, the healthcare system and other sorts of services that could be missed opportunities where infection and wound care, both prevention and treatment, could have been offered. So, understanding where people go and where we could improve care and have some of these lower burden sorts of approaches is really important to kind of getting better services out there. And then overall, I think the last thing that I just thought of bringing up was, what sorts of strategies are most effective at reducing long-term complications of xylazine-associated wounds. So, thinking more about kind of also these missed opportunities, but there's a lot of creative new programs that people are trying out in the harm reduction world to reduce some barriers to care and provide services in ways that are much more accessible to this population. So thinking about which of those work really well and getting some more support through research to understand kind of how we can optimize that is another future step. So I just wanted to acknowledge my colleagues from UNC who are really important for this work, my dissertation committee, and some of my mentors. And I also wanted to acknowledge my colleagues at the North Carolina Survivors Union, who has been really important in this work as well. And then this is a picture of my dog at the North Carolina Survivors Union. She's trying to be a greeter. But yeah, I just wanted to acknowledge the work that they're doing. And something that's been really cool that's come out of this was, the survey that we did was really stemming from what they were seeing in the community. And since then, they've been able to get some grant funding to support their work to reduce some of the impacts of xylazine and get better care for wound care within their program. And so it's really exciting to see both how, in tandem these things can work together, and by doing small scale surveys like this can really support some of the grants that they're putting together. So that's it. I'm happy to take questions.
Sounds awesome. Thank you so much, Mary. And I love the picture of your dog, as well as hearing about some of the community applications of this work that dove so deeply into